Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. Hey, it's my great pleasure to welcome Alon Rabin to today's podcast. Alon, welcome. I'm so excited to talk through some of these things that you're doing. So it's really great to have you on. So welcome.
Thank you. It's very good to be here.
Yeah, cool. Can you tell us about your physio career so far and what it is that you're doing right now? Can you just introduce yourself to our audience?
Yeah, sure. So I'm a PT for I have been since 1998. I think it's when I graduated my PT school, and then I went to work in the United States for about 3 years. I worked at a William Beaumont Hospital in Michigan in the U.S. and outpatient clinic mostly, and I think. I was looking to, I guess, advance my clinical skills and my education background, and I went to one of these residency programs. There weren't very many at the time in the U.S.
Mhm.
It was a sports physical therapy residency in the University of Pittsburgh. So I spent about 2.5 years over there, completing my master's, doing some clinical work, being advised and instructed by really good clinicians and academicians. Um, and then I guess I was reborn as a physical therapist over there. Whatever I learned up to that point, I think I forgot, and I became I got the Pittsburgh DNA at the
Right,
time,
okay.
and they were big on spine and clinical prediction rules
Hmm.
for treating spine patients, and I absorbed all of that. And after I left Pittsburgh, I started my PhD, and my PhD program or thesis was actually in validating an existing clinical prediction rule for predicting success with stabilization exercise
Okay.
for patients with low back pain.
Yeah.
That was a partial success. I think we validated it partially, showing that some of the predictors were predictive and some weren't in our
Hmm.
validation cohort.
Hmm.
And I think at that point, I was pretty exhausted with the spine issue. I was looking for other avenues, and the shoulder was always a big interest for me. And I turned into some shoulder research. In Pittsburgh, actually, I started a project on the scapular assistance test. I had an interest in scapula, and this is how I got to know our mutual friend, Tim
Yeah,
Ull.
right. I was
Um,
wondering where the connection was. So,
yes,
just for
yes,
everybody to
yes,
know, that's how I've met Alon is through Professor Tim All, and we've worked on some different projects, haven't we? But keep me
yeah,
going because now you are back in Israel. You work at the university there. Tell everybody about what
yeah.
you're doing now.
Yeah. I didn't mention that, but my PT background, my PT entry level PT program was in Israel in Tel Aviv, and then
Hmm.
I made the U.S. trip, and then after the Pittsburgh experience, I came back to Israel, completed my PhD over here, and then went into gradually went from the clinic into academia.
Right.
I think now I mostly I only do academia. So I teach and I do research primarily in musculoskeletal shoulder disorders.
Hmm.
I was seeing patients up until a year or 2 years ago, but I think the load, they told me that once in academia. They told me if you want to be a good academician, you got to stop doing clinical work.
Yeah, it's
I thought
difficult,
that,
isn't it? It's such a
yeah,
balance
yeah,
of
yeah.
all the things that you need in your day. It's
Yeah, and
exhausting.
I wanted to prove them wrong, and I did swim against the waves for a while, and then, but finally I think to really focus and really progress what I want to progress now in shoulder research, I
Mm.
really need to give it 100%. So I'm only teaching.
Yes.
I'm doing quite a bit of teaching actually, and devoting the rest of my time to studying shoulder instability primarily, which is
Yeah.
the
Yeah.
main
Wonderful.
focus. And this is how we got to work together as well. It was a
Yes.
project around shoulder instability.
Yes.
Uh,
And so for everybody, this is Alon and I are co-authors on a paper that looks at the supine moving apprehension test. And listening to you say, because you were working in the clinic then with some surgeons and maybe, and I remember you telling me how busy you were running around collecting data. So you did all the heavy lifting with this paper, didn't you? Do you
Yeah,
want
I was the advisor and the student at the same time
Yes,
when I did
exactly.
this project, which is
Can you tell people about the supine moving apprehension test, why we thought it was a good idea, what the research involved, and yeah, what you know
yeah.
about it now?
Yeah, so if we broadly classify shoulder problems that we typically see in the PT clinic, then there are the tendon problems, and there are the stiffness problems, and there are the instability spectrum.
Yes.
Okay, it's a very variable spectrum. And when you assess these patients, so if it's a tendon related issue like a rotator cuff or so, um, a good or sensible test, an asterisk as we call it, would be some sort of a muscular ability test, like a strength test, like a functional a lifting test. Okay, these are good sort of objective measures to gauge progress or the lack of progress in your patients.
Yep.
And if you're treating a stiff patient, then obviously it's the goniometer or whatever other way you have of assessing range of motion. That would be a primary assessment tool. And the question I struggled with was, how do you assess a shoulder instability patient? So how do you know if they're getting better or if they're not, if they're getting more stable or if they're not? There weren't any good physical measures of that, at least not to my knowledge. We always have the self-reported measures, and these are great, but you also want to have something physical to measure. I think as physical therapists, we really like that
Yep.
concept. So there's the orthopedic anterior apprehension test, right? That you take the arm back there and you try to gauge the patient's response, and it's an established test with good specificity in terms of diagnostic value, but it's a yes or no test.
Mm.
Okay, there aren't any grades of instability if you use that test. And also, it's a passive test, right? You're the one taking the patient's arm back there, and you're trying to elicit a fear sensation, an apprehension sensation, really. You're not really testing the ability of the patient to dynamically stabilize the shoulder with this test. You're just testing a sensation which is based on fear, which is based on previous experience, or
Yeah.
all that. So I didn't think that was a very good test for us to use as physical therapists in the clinic to gauge our patient's progress. And looking at other instability problems that we deal in the clinic, I mean, if you sprained an ankle, that's an instability problem. If you sprained your ACL, that's an instability problem. We have tests for that. I mean, you put somebody on a balance board, one shape or the other, and you assess their balance as a measure of their dynamic stability. Or you do hop testing for the ACL, or there are some other tests as well. But we don't have a test like that for patients with anterior shoulder instability. That was, I think, the background or the need
Yeah.
that we thought was there for this patient population. And
And
you're looking
lots of the other tests that we have used, aren't they? They are loading the back of the shoulder, where I was
exactly,
thinking we needed to then somehow expose the front of the shoulder in some way.
exactly, exactly. So those anterior instability patients, and they may dislocate in very, very different ways. I know when I was taught anterior shoulder dislocation for the first time, they told me that they dislocate in with this mechanism, and that's the mechanism for apprehension for sure. But I mean, I'm sure you've had that experience as well. You talk to these patients over the years, they give you a very variable story of how they
Yeah.
dislocated. Not necessarily like that. It may be
No.
in other ways, but once you dislocate, you're going to be fearful in these positions.
Yes.
So just like you said, we need tests that load them in these
In those
positions.
positions. I think.
And
Tell us about the supine moving apprehension test then. Tell us what
yeah,
it does, how,
yeah,
where, yeah, what you, because you've done, I mean, you've done it hundreds of times now, haven't you?
I've done it a lot so far, and it actually, when I was looking at some of the work that you did with Tim, you had a test called the Baber test, right? The
Yeah.
ball abduction external rotation, where
Yeah. I thought
you
I was
hold
going to get the same thing, but the direction of load wasn't enough. And when we
exactly.
looked, there
So
wasn't enough external rotation moment in that action.
right, right. And
That was the
then I
beginning.
started
Yeah.
doing I think I maybe intuitively or maybe after watching that, I started doing the same test with a different load. So I was holding a TheraBand in my
Oh,
hand and it
yeah.
was attached behind me.
Yeah.
And I
Yeah.
was doing the same movement
Yeah. Right.
as the Baber.
Yeah. But
And then
that is exactly the direction of load. But I guess that's, and by lying down on your back, then you can change the direction of the load.
exactly. So if you continue and you just do the same movement,
Yeah.
more or less, while you're in a supine position, then you're getting horizontal abduction moments on
Yeah.
your shoulder, which
Yeah.
is
Right.
good to assess your response if you're a
Yeah.
shoulder instability patient.
I love how
So
at opposite ends of the globe we're moving in the same direction. Do you know? I just love that
yeah,
about this progress. Hey, it's very cool.
the nice thing about gravity, I guess it works in New Zealand and in the Middle East and in the US just the same.
Just the same. Exactly.
Yeah, yeah,
Exactly.
apparently.
Yeah.
So
Anyway.
we we started looking at it as maybe a good measure to assess dynamic stability of patients with anterior shoulder instability. And then we tested a few different angles. So I had patients, I was seeing a lot of shoulder instability patients at that time. I was working with surgeons that saw this on a regular basis, and I would just ask patients to hold a lightweight, what like 1 kilogram, 2 kilogram in their hands while they were on their back, and the shoulder was at abducted to 90 degrees and 135 and 180. And the really interesting thing that we saw was that they weren't really having much trouble holding the arm at 90,
Mm,
but they became apprehensive and very reluctant to do the same thing if you got them above 90.
yeah. Yeah.
So this is why we sort of moved away from testing at the 90 degree and we continued with the 135, which seemed to be the most apprehension provocative position. But
Right.
surprisingly, the 180 is also pretty provoking.
Yeah, I've been
Um,
really surprised since we've been working in that space, and now I often look in range flexion, then I will do an AP glide, because since we've been thinking about this, we know that that is very provocative.
yes, yes, yes. Sometimes I think this needs to be tested, I guess. But if you're going to see these patients when they stand up, they have full flexion.
Mm,
No problem, because there's no posterior load working
yeah,
on their shoulder.
yeah,
But if you put them in supine, they will be very reluctant to give you that same range of motion. So I think
yeah,
the gap, the difference between standing flexion and supine flexion is I think it's a good test for assessing apprehension or assessing instability and maybe gauging it by degrees and not just a yes or no like the apprehension test. But
yeah.
this is a much lower level test compared with the SMAT, the supine moving apprehension test that we
Yeah. So
continue
tell
to
us about
develop.
the paper then. Tell us about that research, what that involved, what you know about the reliability and healthy people, and tell us about that.
Yeah, yeah. So we started looking at what healthy people can do because we wanted to get some sort of I guess, a normative number of what would be expected of a young, healthy individual as he was going back and forth. And the test, just to describe it clearly
Mm-hmm.
to anybody who listens to this, is that you lie down on your back, you hold a 3% weight. So for most people, it's about 2 kilograms, but it could run from 2 to 3 kilograms based on your own weight. And you go from the front of your shoulder to 135, back to the front of your shoulder to 180, and back to the front of your shoulder. This cycle is 1 repetition.
Mm,
This is how we count it.
mm,
And then we ask you to go as fast as you can for a minute, and we count the number of repetitions that you're able to
mm.
complete. So the
Yeah.
score of this test is really a number of repetitions that you're able to complete in 1 minute. And so healthy individuals can go typically between 30 to 35 times a minute.
Yeah, right.
Okay,
Okay.
that's pretty fast.
Yeah.
Okay, men were a little bit had a little bit more repetitions than women, and but really just a few more, not really that many. And you're probably going to do about 3 to 4 repetitions more on your dominant side compared to your non-dominant side.
Okay.
So that is um, what's expected of a normal 20, 25-year-old, because we
Yeah.
didn't test really older ages, since shoulder instability and shoulder dislocation is
Yeah.
it's a young problem
With that
typically.
3% body weight as a
Yeah, yeah,
general
yeah,
rule. And then in the
exactly.
instability population?
And then we we started to test patients, and we didn't want to be very aggressive with them and have them start going right away. We wanted to make sure that we didn't have a safety problem. Because
Yeah.
to be honest, um, when I was first administering this test to patients, I was as apprehensive as they were. And luckily for me, I had a couple of very experienced surgeons behind me saying, "You're okay. Go ahead, do what you want to do. Nothing's going to happen." And it was much because of their confidence that I was able to continue and do this. But we came out with a procedure to make sure that we're not doing something that could be too aggressive for the patient. We just had him, we asked him to place their arm in this position first and in this position with no weight. Okay. Some of them are not willing to do that. If you're not willing to do that, then you can't do the test.
Yeah.
Okay. So if the patients are willing to place their arm in these positions without a weight, then
Yes.
we go one step further and we give them the weight, and we ask them to hold the arm in this position again statically, and in this position statically. And if they can do it, then we try to do the dynamic movement,
Right. And
going
you
back and forth.
assist them through that though.
And initially, what I do is I assist them as they do this, and I'm trying to
Yeah.
feel if they're relying on me too much, or if they're
Yes.
pretty
Okay.
active and they're doing the test on their own.
Yeah.
And if I feel that, and if both I feel that they can do it and they feel that they can do it, and I ask them, "Do you think you can do this on your own?" If they tell me no, that's all I need to know, that they can't go and I can't do the test. But if they tell me, yeah, I can do it, then I would let them practice this movement a few times. And then I would tell them, okay, I'm going to test to see how many times you can complete this in 1 minute.
Yeah.
Okay.
Okay.
And I do ask them to try to move as fast as they can before we start the test, just so they get a sense of what it's going to feel like.
Yeah.
Okay. And if we pass all these procedures and they're okay, then we do the test. Now, what we found when we looked at instability patients is that 60, 70, maybe even more percent are unwilling or unable to do the dynamic portion of the test. Okay. So they kind
So
of stop.
yeah, so let's get that back. They can hold there with no weight. They can hold there with a weight. But as
Well, that's a big question. They can hold with no weight. Most of them can hold the arm there with no weight.
yeah,
Once you put a weight in their hand, about 50% are not going to be able to do
they
it.
said, "Oh
Okay.
no, I don't want to be there. I'm going to bring
Yeah.
it."
And again, I do it assisted first. I give them the weight. I support their arm, and we go together to
Yes.
the frontal plane. We drop the
Yes.
arm until it's in the frontal plane. And then I ask them, "Do you think I can let go?"
Okay.
About half of them would tell you no. no.
So
I mean,
that's
they
an
try.
important safety thing for people who are listening, eh? Most of
Yes,
these
yes.
things, so instead of driving their car to work and they go to practice with their first patient in the clinic, they need to assist them through that range and then be sure that the patient can hold
I think it's a safe way to do this.
to do
You don't
that.
have to assist the patient. You can just tell the patient, okay, grab the weight and then drop it on your own with your own muscle control to the 180-degree position. As long as they can get to the 180 or the
Yeah,
135 in the frontal plane, even if it's independently without me, then I
yeah.
would feel confident about doing the dynamic portion of
The
the test.
dynamic portion if they
Yeah.
can hold. But what you're
Yeah.
saying is a lot of these people couldn't actually even get to that position with
Nope.
3% of body weight.
Nope.
And
Nope.
they were
Nope.
unilateral. You tried them on the other side. What?
Yes, I always try them on the other side first, so they know what's coming. And the interesting thing that we found was if you compare the uninvolved side of patients that have dislocated on one side,
Yes.
then they're much slower compared to a healthy population.
So
So if a,
fascinating, isn't
yeah,
it?
yeah. If a healthy population can go from 30 to 35 repetitions, depending on the side of dominance and so forth, if you look at the uninvolved matched side of a
Mm-hmm.
patient with a previous shoulder dislocation, he's going to do about 20, not a lot more than that. I think we found about 22 repetitions or so in that study. So there, and the interesting question there is, are they not doing it because they've had the experience of dislocation in the other shoulder and they're just
Mm-hmm.
afraid of moving too
Mm-hmm.
fast? Or maybe there's some sort of a general issue that applies to both shoulders of people who have dislocated. We know that
Yeah.
a fair amount
The
of
thing
patients that have
I've been
dislocated.
thinking, like, because then are you thinking, well, maybe there's some, I used to think it was like a tissue laxity thing, but now all this stuff I've been reading about cognitive changes, is it that there are
Right.
cognitive changes that then affect both sides, that affect your coordination in that space?
Yeah, yeah, yeah. So we don't really
We don't
know
know.
why they're slower on that side, but I think it's interesting. It's a good thing to continue and study. Yeah, yeah,
Yeah, yeah, yeah. I'm standing by. Can you
yeah,
tell what were there were other findings from in terms
yeah,
of, I seem to recall a correlation then with internal rotation. There were some other interesting correlations there, weren't
yeah. We didn't publish that, but there was a strong correlation between the test results
there?
and strength of internal rotation tested at 90
At
degrees of angle.
1990.
Yeah, yeah.
Yeah.
We tested at 90. Yeah, yeah. No correlation with external rotation at all, but a strong above zero point 0.7 correlation with shoulder internal rotation strength. But that correlation was found after they've been stabilized surgically. So in that study, most of the patients, about 70% of the patients, did not do the dynamic test before surgery at
In
all.
that they couldn't, they weren't able
No,
to
right.
complete it.
Right, right.
Yeah.
They couldn't do the test. They
Yeah.
couldn't go through all these phases and then get to the dynamic stage of the test. They went, all of these patients were supposed to have surgery later on. So they had surgery. We followed them for the rehab period, so for the first 6 months.
Mm.
And at their last follow-up with the physician, the follow-up where they typically tell them, okay, you're stable, you've gone through enough rehab, go back to doing whatever you want to do, we retested them. So they improved on the SMAT. They,
Yeah.
they didn't practice this at all in their rehab because I don't think anybody trains their patients this way.
Not
I don't
yet.
know that they didn't,
Not
but I'm
yet.
just
Not until
assuming
they
they did.
listen to our podcast and read your
Right,
article.
right. Up
But
until
anyway,
today, no one has done that. But they did go from mostly being unable to do the test to 70, 75% of them were able to do the test.
yeah,
They didn't score very well on the test. They did about 14 repetitions or so, but they improved.
they could do
They
it where
improved.
previously they couldn't do it.
Yeah, exactly. And their score at the 6 months post-op was highly correlated to their internal rotation strength at 90 degrees.
Okay.
Okay. It was also correlated to their WOSI score.
Okay.
Um, and it was somehow, I think we also, and I don't know how strong this is statistically, but the few patients that were able to do this test before surgery, and I'm talking about a third of the patients,
Yeah.
none of them had apprehension, the orthopedic apprehension
The
after
patients
surgery.
who could do it.
Yes, yes.
Yeah.
So maybe there's some predictive value in
Yeah.
this test to predict the outcome after surgery. We just don't have the numbers to say that, but it's an interesting thing to look at. I'm looking at that in one of the current studies that I'm
Because
doing.
it's almost like a self-administered apprehension test, though, isn't it?
It is, it is. I think it
Yeah.
tells you a little bit about their character,
Yeah.
their psychological status, their
Yeah.
willingness to engage,
Yeah.
which is something that they're going to have to face after surgery, right?
Mm.
You stabilize the shoulder, you still haven't taken care of the psychological issue, and we know that there's a huge psychological factor to these injuries. I mean, you diagnose them based on something called apprehension, so there's a lot
Yeah.
of psychology there. Um, so yeah, I think there could be some predictive value in this test as well.
And so
Hopefully,
then step me through, because you've also recently published then a case report, haven't you? Where rather than, because I guess my original conception was around using it as a return to sport measure, but actually it's turned out to be much bigger than that. And now you're using it rather as a treatment technique.
yeah.
Tell us what you're doing there.
So I think there was a very simple logic behind this. I sat down one day and I thought, well, healthy people can go 35 times a minute. Injured patients can go 0 times a minute for the most part. What happens if we get the injured patients to go from 0 to 35? First of all, can we do this?
Yeah,
Okay.
right.
If we gradually train them just at doing this test, can they get better at it? And if they get better, do they get better to the same level as healthy individuals, or maybe
Mm.
they can max out at 20, 25 repetitions? And if they do get to that level, 25, 30, 35, whatever level they get to, do they get healthier? Do they get more stable?
Yeah.
Okay. Do they function better? So that was the question really that drove I think my clinical behavior. I
Yeah.
started using this in the clinic. I wasn't thinking research at the time. I was thinking, let's just use this. This is a unique exercise. Patients have you ask patients to do this, and they will straight away tell you this is nothing like other physical therapy exercises I've done before, because it isn't. It isn't. It's
No, because
completely
it
different.
really exposes them.
Yes, yes, and I think most therapists, and this is something that I hope to raise a little bit of knowledge about. I think therapists are very hesitant about loading their
To be
patients
fair, you
properly.
were a little bit hesitant when you
And yes, I'm not saying this in a critical way. I was in that under that hat
Yeah.
myself. I was extremely apprehensive about doing this. I wanted that minute to be over very, very fast.
And so
So
the thing, because I guess safety is paramount here, isn't it, for
absolutely.
people? We definitely don't want people dislocating doing this test. And so just for clinicians to be aware, just to reiterate those three stages, that you would take them back and assist them. Are you okay if I leave you here without a weight at 135, 180? Then you give them a weight and you guide them. Are you okay if I let you go here? Or they guide themselves back here, whichever
Exactly.
the therapist prefers, I guess. But the failure of the test is the inability of the patient to keep moving the arm. Is
Yeah.
And then you move into how many reps. But what we're learning about this is actually what's maybe like, again, I know you don't want this to be dichotomous, but it really is, isn't it? You either can do it or you can't
Yes.
do it, rather
Right.
than how many can you do, which is maybe what we thought was going to be interesting, actually not as an interesting finding is can you or can't you?
Right. Right. I think that's reality. Yeah. Yeah.
Yeah. And so tell
And
us about the training then. And so instead of using it as an assessment tool, tell us about this case or what you're doing
so
to be brought more broadly.
yeah, so we broke it. We wanted patients to go 35 times a minute.
Yeah.
Okay. We wanted patients that are unable to do it to go 35 times a minute. So we broke it down to three phases. the endurance or the static phase, the dynamic phase, and a neurocognitive phase. So the first phase is the static phase or the endurance phase. And this is where we give him a load, maybe the 2 kilograms, maybe just 1 kilogram, whatever they can handle. And we ask them to get the arm as close as they can to the frontal plane at
Yeah.
135 and 180. And this is done in supine lying, obviously.
Yeah.
And if they can go all the way to frontal, great. We start just training them there, just holding the arm there. So we do about 20 repetitions, 10 seconds each repetition, just holding.
Yes.
Okay. We called it the endurance phase, but it wasn't really based on any solid data on how many seconds you have to hold the arm there to gain endurance. And we're
Yes.
not even testing their endurance, but we really, what we're doing is we want them to get used to this feeling
Yes.
and
So
to
there's
be in
both
this
a sort of a
position.
familiarization, but still
It's
at
an
20 minutes
exposure.
or 10 seconds, you're into
Yeah,
that endurance muscle building, aren't you?
exactly. Exactly.
Yeah.
So we do this at 135 and at 180. And we
Yeah.
do it, I would say, do it minimally for 2 weeks. I mean, we did it in the case study for about 4 weeks. We went
Yeah. Right.
from holding half the weight in scapular plane, 135 and 180, and then holding full weight in scapular plane, 135 and 180, and then going back
Yeah.
to frontal 135,
Yeah.
180. So
Right.
that took us, with that
The
particular patient that
progression.
was very apprehensive, that took us about 4 weeks.
And can
And
I just
after 4 weeks,
interrupt here? Because at
yeah,
any space, I know you're a subscap guy, as I am a
yeah.
subscap girl, at any point, because it sounds very similar to how I would train subscapularis by instead
Yes.
rolling back into, at any point, are you palpating in their armpit on their subscap muscle
I
belly?
wasn't up until now, but you just gave me a good idea. Yeah, I agree.
We
I
need to get
wasn't.
Tim organized with some EMG, don't we?
No, but I do have, I started doing an EMG study, an indwelling subscapularis,
Yes?
all rotator cuff. So I do have some data on that. I know the subscap is working.
Yeah,
Okay,
right.
we've done 13 patients or subjects, healthy subjects so far. It's definitely working in both positions, the
Yeah,
subscap, and the posterior cuff seems to be a little more quiet.
yeah.
Like you and I would expect. I know some other people have some other
Yeah,
issue
would not
or
expect,
opinions.
but yeah, we would
Yeah,
expect
yeah,
that.
yeah. I know the whole posterior cuff is really the anterior stabilizer over here, or the anterior cuff. There's a whole debate on that. But I know from an EMG point that in these end range positions, the subscap is definitely working.
Yes, so Karen, Jen,
Um,
and I have had some very nice conversations on this podcast around that anterior posterior cuff, but that's
yeah.
for that's for another day if people are interested. Is there, just so I can pick into what you know about that, in some people is there less activity or different activity in different ranges? Have you noticed anything there?
Well, I haven't analyzed it to the extent that I want so far, but it does seem that when you go from here to the 135, your subscap is pretty quiet down
Hmm.
here
Yeah,
and on the way. But the closer you get to the end range and that apprehensive position, the graph of the subscap goes up.
yeah.
Okay.
That's what we would expect
And
though,
and
isn't
the
it?
the posterior cuff is completely opposite. So if as soon as you push and you start the movement
Yeah,
toward the 135, you get a spike in the supraspinatus and the infraspinatus,
yeah,
just as you would in the anterior delt, because
yeah.
you're pushing. That's
Pushing
what you're
out,
doing.
yeah.
But as soon as the arm starts decelerating
Lower.
back there, their graph goes down in most people. Okay,
Yeah,
that's the tendency. So you have a reciprocal activation of your calf, of
yeah.
your cuff, of the rotator cuff, and that is it's not unusual. I mean, there has been studies, I think, out of Australia, maybe Karen Ginn's group, that have
Mm.
shown that the cuff is direction
Yes,
specific,
yes,
right? So the
yes,
posterior cuff is a flexor, so to speak. The
yes.
anterior cuff is an extensor. So we're seeing that with this movement as well.
Same thing. But I guess what's unique now about this position is where you are loading them into a provocative, injury-provoking position, isn't it?
Exactly.
Move
Yeah.
us on then. So you've done the
Okay.
endurance training, then you move
Right.
into dynamic.
And then and then after you've done 2, 3, 4 weeks of static,
Yeah,
then they're in a much better position to start doing the dynamic pattern.
yeah,
And initially, all we say is, okay, all right, let's try to move at whatever pace you feel comfortable.
With
in the
low weight,
dynamic
or you,
with full weight, with 2 kilograms or three
okay, you
kilograms
take
weight
them
on
to the
your own weight.
3%. Yeah.
Yeah, yeah, yeah. And
Okay.
most of them can do it by that time. They're not as apprehensive about doing this. They can do this. The patient in the case study was able to move at a 10 repetitions pace, 10
Yes.
repetitions per minute pace
Yes.
after the
Okay.
4 weeks. And then we try to increase the pace every week or
Yeah.
so
Right.
based
You
on the
use a
patient's
metronome
ability.
for that, or you just ask them to go
Yes.
faster?
With the case study, we used the metronome. They loved
Yeah.
it.
Right.
And
Yeah.
it,
Yeah.
it kind of gives them a
A
really
beat, eh?
nice,
Yeah.
yeah. Yeah. And we increase the pace weekly or as they're able to. It doesn't have
Yes.
to necessarily be every week, but we try to increase the pace to what we know healthy people can do. So I would continue to increase the pace until they show me 30, 35 type repetitions,
Yeah. Right.
or until they tell me, look, I can't get any better than that.
Yeah.
And
Yeah.
with
That's
this
it.
patient, he wasn't able to get, he was able to train at 30. He wasn't able to get past that.
Mm.
And once they're at a good pace, and with this patient, we started this at, as soon as he was able to get to 25 repetitions a minute, we started the neurocognitive phase.
Yeah.
So,
Tell me about that.
and so we wanted to turn their attention away from their shoulder as they
Yeah.
were doing this, right? Because you
Yeah.
dislocate when you're not thinking about it. You don't,
Yeah.
patients are not going to dislocate typically when they do exercises when they're thinking and they're focused on their shoulder because they're focused on their shoulder.
Yeah.
But when you're focused on other things,
Yeah, but
it
that's what
happens.
we know around some of that distraction, isn't it? And, from a motor learning point of view, making it automatic processing.
Exactly.
Yeah,
So in
okay.
order to make this an automatic process, what we did is we coded these different directions. We gave him numbers. So we said, I'm going to read out different numbers to you. They're comprised of the numeral 1 or 2. So it could be 11, it could be 12, it could be 22.
Okay.
Every time you hear a 1, you got to go to the 135. Every time you hear a 2, you got to go to the 180.
Yeah.
So if I tell you 11, you got to go 135, 135.
Yeah,
And
okay.
if I tell you 21, you got to go 180 and then 135.
Okay. Yeah.
Okay? So they're
Yeah.
not like monotonously doing this and they can sort of fall asleep and continue to do this because they're used to it.
Yeah, but it's more reactive.
Exactly. So they have to, it activates memory because
Yeah.
we shout these numbers at them at a very high pace, at a
Yes.
25 or 30 repetitions
Yes.
per minute pace. So these numbers accumulate and they have to, okay, I have to do 11, then I have to do 22, then I have to do
Yeah, right.
21. And
There's a
then we
lot of
start doing this
cognitive
with both hands.
processing. Yeah.
Yeah, so we throw numbers comprised of 3 and 4. So if you hear a
Okay, then you don't
33,
do anything.
no, if you hear a 33, we had him go with the opposite arm.
Oh, okay.
135, 135. Okay.
Okay.
So you don't know which arm you're going to do,
Do
and you
that
don't know
with.
which direction you're going to do it in.
Yeah.
So and it's taxing. They will tell
Yeah.
you it isn't easy.
Yeah.
Okay. And so we train them at a 25, 30 repetitions per minute pace neurocognitively. Okay.
And you
Using
have
these number
tried that
codes.
with healthy people? I mean,
No, no, I
I'm
haven't.
just interested because we're doing a little project at the minute with the blaze pods and they're
Yeah.
looking, which is similar, but we're just reacting to light rather. That means I don't have to shout at the patient. But they find that the perceived exertion is harder in the affected side,
I
which
wouldn't
is
be
what you're
surprised.
saying.
Yes. Yes.
Isn't
They
that
find it
wonderful?
very challenging.
Yeah.
Um, yeah, we love that part. They love it too because
Yeah, because it's interesting, eh? It's not
yeah,
boring
yeah,
physio.
yeah. There's no compliance problems with that. And I think
Yeah.
also that's the nice thing about this. We give them one exercise during this whole program. I know there's some criticism about that, but I mean, Achilles tendon patients do one exercise many times, and
Yeah.
patellar tendon patients do one exercise at the time. And Robin McKenzie, I don't want to go. I know that if I'm going to say Robin McKenzie said go and do extension, a lot of McKenzie people are going to be upset at me, and I am talking to a New Zealander, so I don't want to start that. But they do a lot of
A lot of
one
things
sort
have
of
one particular
exercise.
exercise, and you are loading them into their provocative sign. I guess the criticism would be there's probably some other deficits that you're not addressing.
Yes, and there, and I don't know that I'm saying, drop everything else, just do this.
Yeah,
But we are looking at it in a study, in a clinical study right now. We are looking at this as a complete intervention. Okay, just a
yeah,
one exercise intervention versus sort of standard care, what you would call, which is whatever the
yeah.
therapist feels that needs to be done with the patient. We are comparing that. We'll have some data on that, but
We
that's gonna
can
take
we
a
can
while.
meet for another podcast. I'd be
Yeah,
interested to you just reach out when you're ready to chat.
yeah,
It's so interesting, isn't it, how this is developing and where this is going. What do you
yeah.
think? Like we need to wrap this up so people can get to work and what's important for clinicians about this? What's the t key takeaways for them?
I think do not be afraid of loading your patients
Mm.
into provoking positions. I think that's actually the way to go. I
Yeah,
think we have to look at this as sort of an exposure therapy. You're afraid of something. You're afraid
yeah,
of getting the arm there, and you're gonna limit yourself and avoid many
yeah,
things that involve getting the arm over there, which is grabbing something from the back seat of the car or pulling a blanket to cover or a
yeah,
million different of other things that you hear these patients tell you that they're afraid to do, but
yeah.
they're afraid to do it not because they dislocate every single time. They're just afraid that they will dislocate. And most of the times they don't,
So tell
right? They
us
don't
before
dislocate every
we,
time.
because the patient, his kinesiophobia score decreased, his
Yes,
WOSI
yes.
score, I mean, his quality of life improved, but his kinesiophobia came back high again, didn't it? Tell
Yeah,
us about that
yeah,
before we
yeah.
wrap up, because I think that's a really interesting thing for
So
clinicians to know.
at the end of the intervention, their kinesiophobia dropped to
Yeah,
even below what's considered high kinesiophobic level on the
yeah,
TAMPA scale. That was based on the 17-item TAMPA um, scale. But then we asked the patient to continue doing this exercise at least once or twice a week, if not every day. And we met him again about 4 months, I think, later. His WOSI score stayed pretty much the same as it was after treatment, but his kinesiophobia came back. So he scored high again on kinesiophobia. He was, based on his report, he was doing this once a week.
yeah,
He was doing the exercise once a week. Didn't really dislocate again, but his kinesiophobia level was up. So I don't know how lasting the effects are,
yeah,
uh, but I think it's a key outcome that we have to follow and that we want it to drop.
yeah.
I think
Well,
they
like we
sort
were
of
saying
self-inflict.
before we
Uh,
came online, we know that kinesiophobia is a independent, univariate, multivariate predictor of recurrence,
yeah,
so
yeah,
addressing
yeah.
it seems to be very important. And this is a very cool way that you've found to actually make a change there. Do you have any closing remarks for clinicians? I can upload the paper, can't I, so that they can
Sure.
look at your case study. What's your closing remarks for clinicians? Don't be afraid.
Um,
Don't let them be
Again,
afraid
do
and to
not be
load.
afraid to load your shoulder into apprehension provoking positions. I think if you're not doing that, you're not giving them the best opportunity
Mm,
to rehabilitate themselves. They need to rehabilitate the motor ability, but I think more importantly, they need to understand that they can get the arm back there. The sky
yeah,
doesn't fall. They don't dislocate every single time. Once they
yeah,
get that confidence, I think you're doing a lot of good for these patients. So
yeah.
I think that's just don't be afraid. That would be my suggestion.
It's a wonderful closing remark. Thank you very much for your time, Alon. I look forward to connecting with you again as these other papers come ready for
Oh, we will,
publication.
definitely.
Yeah.
Definitely.
Thank you.
Thanks, Margie. I appreciate it. I've had a good time. Thank you.
Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment and rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.